talk about liver biopsy. I'd like to go over a little bit what it's used for and what can go wrong. I think the most important question to ask when you're going to do a liver biopsy is, will it change my therapy? Because although lots of times we would like to know what the liver looks like, in practicality, if it's not going to change what you do, you should really think hard about doing it. So the questions that you would ask is, will it give me a diagnosis? Will it tell me how bad it is? Is there another way I can get the information? Are there special risk factors for this patient? And what method of liver biopsy should I use? Liver biopsy is an incredibly safe procedure, but sometimes things go wrong, and when they go wrong, they can go very badly wrong. So you need to make sure that you think about all of these things before you do a liver biopsy. So will it give me a diagnosis? What does it look at? So it looks at bile ducts, looks at portal veins, hepatic arteries, central veins, hepatocytes, and sinusoids. So what kind of things is it good for? Well, it would tell me the kind of inflammation there is. So things like autoimmune hepatitis, it's really good for that. Rejection, we sometimes use it for viral illness or to look for drug toxicity. It's also really good to look for storage material, either the regular histology or EM. You can see fat, you can see glycogen. You can see other things like storage material from iron or Niemann-Pick. So for those kind of things, it's really good. It can also tell you severity by telling you the amount of scar that's present, as indicated in the top picture. The blue is fibrosis. It can tell you the amount of infiltrate. It can tell you if you've had collapse because all the hepatocytes are gone, and it can tell you how bad rejection is. It's not very good for vascular issues. Usually radiology is more helpful for that. It's also somewhat problematic with neonatal livers. We use it a lot for neonatal livers, but you need to know and acknowledge that there are very few things that the neonatal liver can do in response to stress and injury. And so they almost all have giant cell transformation, and bile duct issues can sometimes be hard to tell because sometimes with something like paucity, where you don't have very many bile ducts, you get this bile duct proliferation, or maybe the bile ducts aren't gone yet, and so you don't actually have paucity when that's the diagnosis. So you need to go into it knowing that you may be confused. I always tell parents that there isn't a little flag that the hepatocyte has up in the air that says, you know, I have bile duct paucity or I have biliary atresia. You sometimes have to put a lot of things together. So what are the methods? There are 4. You can do a blind either suction or cutting biopsy. This is a technique that I originally used, where you advance a needle up to the liver and then either with a cutting needle that will cut a little piece, or use suction on the syringe as you punch in and pull out, and it sucks a piece up. This is done by percussion, sometimes with ultrasound beforehand, but is mostly a blind procedure. At Children's, we tend to do them under ultrasound guidance. So while they're actually looking at the liver, they advance a needle to the liver edge, and that needle has a mechanism that shoots out and cuts a piece out. They can then inject gel foam into the plug to prevent bleeding. In people that have a high risk of bleeding, we sometimes do transjugular biopsies where they go into the jugular vein down through the heart and hepatic veins and wedge into the liver and take a piece there. Those pieces tend to be small, but can be very useful if you're looking for a cause of, say, fulminant hepatic failure and the coagulopathy, or ascites is too bad to do a percutaneous approach. And then we also have open or laparoscopic biopsies that are done by the surgeons for us. So what are the risks? You never want to get into this situation where a patient is having marked distress after a liver biopsy from a complication. So what can go wrong? Bleeding is the most common complication. It usually happens in the first 4 hours. It can either be subcapsular, which would seem like it would be good because it's contained by the capsule, but that capsule can rupture and have really severe bleeding. You can also have intraperitoneal bleeding. If you have someone who had infection in their liver, say cholangitis, you can seed infection with the liver biopsy. And so people who have abnormal ducts, we often cover with antibiotics beforehand, but you can certainly have someone get septic a couple hours after a liver biopsy. So what happens if a patient is doing poorly after a liver biopsy? I think the most important thing is examine the patient. Check their vital signs. Did they have abdominal tenderness, which would make you think they have intraperitoneal bleeding? Are they short of breath from a pneumothorax? From it, how are they doing? Do they look like they're anemic, i.e. Tachycardic and hypotensive? We usually get a stat hemoglobin and ask for stat ultrasound. You have to make sure that the tech knows that you're looking both for a hematoma in the liver and bleeding in the peritoneum. We missed a bleed inside the liver once when they only looked in the peritoneum. You also need to think about sepsis and treat that if it's a possibility. So this is a picture of a liver biopsy that shows a sinusoid, and it has some dilatation of the sinusoids and congestion. But otherwise, it's a pretty normal liver biopsy. This is a picture of hepatocytes that don't look normal. They look really cloudy. Maybe they have some glycogen. So liver biopsy is certainly good for that. Here is another picture of sinusoids. You can see that there's some collagen around, and then you have lots of congestion into the liver. This is probably something like right heart failure that's causing an outflow obstruction to the liver. Veno-occlusive disease can also cause congestion of sinusoids. Here is a picture of liver fibrosis in the big panel. You can see the nodular cirrhosis with the blue being the trichome staining of the fibrosis. And the other panel, you look at the stages of fibrosis from a normal liver to some portal fibrosis, and then it starts to bridge and then goes on to cirrhosis. This is another picture of what you can get from disease severity. This is someone who has massive necrosis of the liver, something like Tylenol toxicity, where you're getting massive necrosis. Most of the time, kids like this don't get a biopsy because we're able to figure it out some other way, and there is certainly risk to biopsying a liver like this, especially bleeding. So, is there another way to get the information is one of the questions that we needed to ask. If you're looking at blood vessels, radiology studies are often helpful. Sometimes blood tests will help us. We try really hard to get the information some other way, but sometimes we just need to biopsy the liver. And then, what are the unique risks of this patient? Do they have thrombocytopenia? Do they have coagulopathy? Is there something we need to correct? Do they need IV antibiotics? These will all help you decide what method and what monitoring to do for your liver biopsy. I hope this helped you understand why we do it, what we can get from it, and how to take care of the patient that's having complication. Thank you.